Hello, my name is Octavia Ingram, and I did my case study on Mr. Estel. Mr. Estel is a 74-year-old male. He completed 4 years of college and was a former athlete. He retired at age 65 as a plumbing contractor. He is brought into the office today for a neuropsychiatric evaluation. He is married and lives with his wife. His brothers brought him in today for his exam. History of present illness. He's experienced a multi-year decline in mental status marked by stiffness, forgetfulness, and apathy. According to his wife, he is uncharacteristically forgetful, misplacing items, and neglecting bills. He has trouble remembering appointments, medications, and performing calculations. His symptoms began 9 years ago at age 65 once he retired. He was involved in an accident due to inattention and diminished depth perception and had to stop driving. He cannot recall the outcome of sporting events on television just after watching, but memory improves with cues. He resists activities previously enjoyed, such as traveling and socializing. After several falls, he has stopped taking walks and he quit playing cards because the rules were confusing. He is often unable to operate household appliances. His wife reports that sometimes he is almost like his old self, and other times it was like living with a zombie, a depressed zombie. He has excessive daytime drowsiness and frequent staring spells. His wife reports sleeping on the couch after several episodes of her husband acting out his dreams. He punched and screamed in bed and left her with bruises. She gave him a sleeping pill that caused extreme rigidity and confusion, and she nearly drove him to the emergency room. It was a sleeping pill that he got from a friend of a wife that also had dementia, and it seemed to help that friend, so she thought it was okay. He often swats at invisible things in the air, and these episodes happen about twice a month. His medical history is pertinent for hypercholesterolemia, cardiovascular disease with stents, and transient ischemic attacks. His family history is positive for his mother having developed dementia in her mid-70s. On examination, Mr. Estel was a stooped, stiff man who shuffled into the office. While listening to his wife present the history, he often stared into space, seeming to pay no attention to the content of the conversation. His right hand was tremulous. He appeared depressed, but when asked, he said he felt fine. His voice was so quiet that words were often unintelligible, even when leaning close. He drooled at times and did not notice until his wife wiped his chin. When asked to do cognitive testing, he shrugged his shoulders and said, "I don't know." In developing differential diagnosis for Mr. Estel, you have to include Alzheimer's disease, major neurocognitive disorder, post-traumatic stress disorder, Parkinson's disease, Lewy body dementia, and major depressive disorder. Key findings. Over a multi-year decline marked by stiffness, forgetfulness, and apathy, he is brought in for mental evaluation. Uncharacteristically forgetful, misplacing items, and neglecting bills. Trouble with appointments, medications, and calculations. After a car accident due to inattention and diminished depth perception, a physician suggests he may have early dementia. On examination, Mr. Estel was a stooped, stiff man who shuffled into the office. The right hand was tremulous, he drooled at times, and he had unintelligible speech. His wife had even begun to sleep on the couch because her husband began to act out his dreams. A friend offered a sleeping pill that he responded to with extreme rigidity and confusion. He often seemed to sweat at invisible things in the air. He often stared into space, seeming to pay no attention to the content of the conversation. And the diagnosis for Mr. Estel is Lewy body dementia. This is caused by abnormal alpha-synuclein deposits in the brain called Lewy bodies. Lewy bodies cause problems with behavior, movement, cognition, and mood. Over 1 million individuals in the United States are affected. It typically begins in the 5th decade of life or older, and it affects more men than women. Clinical manifestations include Parkinsonism, visual hallucinations, cognitive fluctuations, and rapid eye movement sleep behavior disorder. Prominent deficits in attention, executive function, and visual spatial skills. Cognitive fluctuations are a core clinical feature and hard to distinguish. Examples include daytime drowsiness, blank stares, and disengagement in conversation. The rationale for diagnosis in this case study include that the patient must first meet the initial mild or major neurocognitive disorder criteria with insidious onset and progression. The cognitive deficits precedes Parkinsonism. The suggestive features are the REM sleep behavior disorder. The hallmark symptom is fluctuating changes in attention and executive function. Sleep disturbances are present in 80% of patients with recurrent dream enactment, vocalization, jerks, punching, or kicking. Autonomic dysfunction is present in 30 to 50% of patients, and signs and symptoms include orthostatic hypotension, constipation, bladder incontinence, excessive sweating, erectile dysfunction, repeated falls, and syncope. Cognitive fluctuations are noted by Mr. Estel, and they include daytime drowsiness, blank stares, and disengagement in conversation. Anticholinergic medications block acetylcholine and may induce delirium, and this is evident by Mr. Estel taking the sleeping pill, and it caused an extreme rigidity and confusion. Intervention and treatment plan. The treatment targets symptoms to improve quality of life. Medications do not prevent or slow disease progression. Patients must decide which symptoms are most problematic to develop individualized courses of treatment. Avoidance of antipsychotics due to severe neuroleptic sensitivity reactions. These reactions cause profound changes in consciousness, which can be fatal and occur in 50% of people with dementia with Lewy bodies. Assessment tools needed are the mini mental state examination, the Mayo fluctuation scale, the clinical assessment of fluctuation. These are all tools that can be used to assess cognitive function in patients with dementia. Psychoeducation for the patient and caregiver is pertinent. You must explain the diagnosis, symptom control, and establish priorities due to the treatment of one symptom worsening another symptom. First-line treatment for neuropsychiatric symptoms include caregiver training, physical activities, social stimulation, and environmental modification. Safe, constant environments with orientation cues are ideal. Physical exercise. This helps improve cognition, motor symptoms, and mood. Neuroimaging. CT and MRI are used in dementia with Lewy body because there is preservation of medial temporal lobe structures, and there's also done to evaluate cerebral atrophy. What you will find here is loss of pigmented dopaminergic neurons in the substantia nigra. Another test used is the single photon emission computed tomography. Here you will see 78% sensitivity and a 9% specificity for non-DLB. Also, another test that can be used is the photon emission tomography, and here the cingulate sign is ideal because it shows that there is sparing of the posterior cingulate relative to the precuneus and cuneus. This is specific 100% specificity and sensitivity of 62 to 86%. Positive for patients with dementia with Lewy bodies. Another important intervention is physical therapy. Physical therapy decreases motor symptoms and improves balance. Here is a list of the common medications used in dementia with Lewy bodies. To begin, carbidopa and levodopa, and is dosed at 25 per 100 milligram tablets. 1/2 tablet is dosed 3 times daily to manage motor symptoms, and this medication is titrated based on patient response. Melatonin is ideal for sleep, although clonazepam is used sometimes, but it's rarely used because of the side effects that it does cause. Mirtazapine or Remeron is dosed at 15 to 30 milligrams, and it is for REM sleep behavior disorder. Donepezil, 10 milligrams, is used to improve cognition. Momentum or Namenda, 5 milligrams for stiffness. And Midodrine is 2.5 to 5 milligrams for orthostatic hypotension. And in treating all these symptoms, it is important to set priorities with the patient so that whatever symptom is most problematic for the patient is treated, because treating one symptom over the other may cause worsening depending on the medication. So priorities need to be set with the patient on what's most problematic for them to develop treatment plans. On this slide, I've included my references. And here my references are concluded. And if you have any questions about anything on the presentation, I can be reached at octavia.ingram01@utrgv.edu. Thank you.